to us
Kriti.
and your work at Collins Institute, please.
Yeah, thank you very much. It's an honor and a privilege to be here with you today at Metakosmos. I appreciate the invitation. I'm the academic director of the Collins Institute, which, as you now know, the Collins Institute is a joint venture partnership between the University of Sydney and the Northern Sydney Local Health District. We're actually the oldest medical research institute in New South Wales. We're about 103 years old. So we've got a long-standing history of producing groundbreaking research from basic science to translational science, and I'm very honored to be in the role as the academic director and have been in that role for the last year.
Fantastic. So we'd like to know a bit more about the muscle map work happening at the Institute, and what does that really mean? Because we look at images of the human anatomy, and we assume that that's just it, but my understanding just runs as deep as that image maybe. So I'd be more than curious to just know what is a muscle map.
Yeah, well, thank you for asking. I'll tell you, if I could give a little bit of a background there. I myself have been fascinated by muscle for 20 some odd years. I was trained as a physiotherapist and was primarily practicing and working with patients who had chronic pain. And this was in the United States at the time. And the majority of them would come to the clinic with their MRI scans. Yeah. And not knowing much about MRI back in those days, I said, boy, those muscles don't look very healthy to me. Yeah. So, being an inquisitive, curious person, like all of us, I knocked on the door of all the radiologists I could find and say, hey, what do you think? And of course they said, yeah, well, that looks like that's fat inside those muscles. But it's probably because they're not healthy people. And that just didn't sit right with me, because we lived in Boulder, Colorado. And Boulder, if you know anything about Boulder, Colorado, I mean, people drive their bike 60K before they even go to work. You know, that's a very fit population. So that embarked us on this really long process of trying to understand, when might we expect muscles to sort of degenerate over the course of lifespan in a healthy way. Mm-hmm. So over the last 20 years, we've been sort of working towards this evolution of establishing what we're calling a muscle map, so that we have an ability to know that, you know, these are normal course age-related changes in skeletal muscle for men and women across across racial cultures.
All kinds of demographics.
Yeah.
So would this be right to say that the work on muscles also relates to aging? Because there's a lot of conversation in the Valley right now, I'm sure you've heard about startups trying to think of aging as a disease. So would this fit into that piece at all? Or?
Without a doubt. Yeah, absolutely. I think no different than, say, you and I, we go to our GP, and our GP orders a blood sample, and you know, we come back a week later and he or she says, hey, Kriti, your blood sample looks great, your cholesterol's good, your triglycerides are fine, you might be a little high here, but we'll keep an eye on that. We don't have that information with regards to skeletal muscle. We don't know when we might expect to see some normal age-related changes. Yeah. Yet what we do know is that there are some profound changes in people who have various diseases or various disorders, such as low back pain, such as diabetes, that their muscles seem to rapidly degenerate. But again, without having normative reference values, how do we accurately compare that across people?
So would you reckon reducing the time to measure these things would be a critical factor in this entire piece? Because you hear about technologies making it easy, and there's lots of AI conversation around diagnosis. So we still go to the hospital and we realize that there is a bit of a time lag in terms of when you identify your issue till the time you actually see the doctor for the diagnosis to happen. So what is happening in that space, and do you think crunching that time would make a difference?
Yeah, you know, I can tell you, myself and colleagues around the world have spent an enormous amount of time drawing geography around muscles on MRI scans using specialized software, and it's probably why I have right arm pain, to be honest with you, because it's so difficult to do and laborious and time consuming. So to answer your question, with the technological advancements in AI and deep learning has drastically changed the way we actually assess and measure and record these muscle changes. I know of no radiologist in the world who would have the time to actually do this manually, but if we actually switch it now into a deep learning artificial intelligence algorithm, I think that's a game changer.
And do you reckon that could ever be made a consumer application so people could do the first point of diagnosis at their location?
How fascinating. I guess the simple answer to that is why not? You know, I mean,
Because everyone's got devices and they
absolutely, you know, and if we have an open source portal where people could potentially upload their scans, which is currently, you know, growing across the world, as you know, and our goal with the muscle map is working collaboratively with colleagues around the world, and we're very, very excited to say that sort of on the sniff of an oily rag, we've been able to leverage the good faith of our colleagues and have just under about 100,000 scans, head to toe, MRI and CT, which my colleagues at Stanford, Ken Weber, and Vrije University, Ado Vestlink, are helping to build these artificial intelligence algorithms to measure these muscles in rapid, accurate fashion.
Yeah, and in our engineering world, would they be classified as high fidelity human models that you could potentially use as a proxy for assessment and training?
Yes. Ultimately, what we really truly need, though, is that, and it won't surprise you, the majority of our data sets over the years have been collected in the Western world. So we have a very high population of data from men and women of Caucasian sort of background. We clearly need to expand those data sets to have an ethnographic, have the ability to look at the ethnographic changes that you might see. Yeah.
And have there been any efforts now to sort of make that data more diverse? Because it might skew your analysis, is my understanding. Because our next question kind of relates to a very similar space where you need more diverse data points, but we don't have them today.
Yeah. It is a massive goal of ours to increase the diversity and richness of our data.
That's right. Moving the conversation to space, obviously, I'm sure you're aware of all the harmful impacts of space radiation and microgravity on the human body. One thing that amazes us, because we're working on devices or suits that would have to go on top of the human body, is all the injuries that people have sustained when they've engaged in the life cycle of human spaceflight. And there is, again, very limited data. Barely 600 people have been to space, so we'd have to rely on the information we have from these 600 people. But what stands out at the top is obviously musculoskeletal injuries. So do you reckon that any of the research that's happening here on Earth could be translated to these things in the future? Or do you have any thoughts on that?
I do, for sure. First of all, I am very new to this space industry, if you will, having just recently met yourself at the Space Colloquium and working with folks like Professor Gordon Cable and John Cherry, Julie Hides. So, and I myself have never been to space. I'm not one of those 600s. I myself have also had plenty of injuries on Earth. If you look at musculoskeletal disorders, in actual fact, they are one of the leading burdens of disease in the world. Since tracking that since 1990, the Global Burden of Disease studies have looked at these, diseases that actually are getting better or not so much. Things like tuberculosis and malaria. They've gone from a high burden of disease to a much lower burden of disease over the last 30 years. Why? They have diagnostic tests, they have known pathophysiology, we have good interventions for treating those diseases. So naturally they go down in their burden. MSK disorders actually have gone right up the way. So low back pain, for example, neck pain, they are at the top of the list of a global burden of disease problem. And I think the question then becomes is why? And I can appreciate hopefully the rhetorical nature of this is that, well, you know what, they don't have a gold standard diagnostic test. They don't have really known pathophysiological mechanisms, and therefore we don't have really great treatment interventions for them. So I think we can learn an awful lot from our experts in MSK, medicine and rehabilitation as we explore life in outer space.
And to stress on that point around gold standard for measuring these things for early detection, are there methods currently that are more invasive or non-invasive? Because my understanding is a lot of times people experience these things in the field or at their workplace. So is there a way to manage these things without actually going to the clinic? Because that might actually, again, improve the time or kind of, increase the actual identification of the problem?
Yeah, no, it's a good question. Look, from a muscle map perspective, apart from having to have a scan performed on you, it's a very non-invasive measure. There's nothing I need to stick inside and pull something out and look at it under a microscope. But I think what we are leaning towards is, almost like a disparate data project, Kariti, where you have access to data and informatics. So an electronic medical record that has your previous blood tests, has your previous history with your GP, your imaging studies, all of that data should become available, obviously through consent of the patient. And that's where I think these associations can be developed and understood as to, what's driving your clinical course may be very different than what's driving my clinical course, even though we have the same diagnosis. So I think the push towards using existing data is absolutely crucial for us to answer, the questions as to why do my MSK disorders in this case continue to get worse, not better.
Yeah, that makes sense. And because you've been talking about consent and data from the patients, and I've had some exposure to GDPR in the technology world, and it's a very touchy topic today. So could you talk to us about the standards that are currently present in the medical data world and how they could be used for research purposes like these, and how common people could add their data sets if they would like to contribute?
I'll tell you what, I think the simple answer to that is trust. There has to be clear, consistent, cohesive communication with our community members as to, why, when they walk into our hospital, are we asking them to consent to provide their data for us? And quite naturally, I think of my aging parents who have now passed away, but they would have found it very odd if someone asked them, please share your data with us. That's their data, why would you? But I think, perhaps younger than me, your generation and others, I don't think any of our patients should ever be surprised, bewildered by being invited to participate in a research study when they go to visit their GP, go to visit their hospital, and the reasons are very clear. With your data, we can now start to help develop data sets that can help us cure disease, help us cure these problems. More importantly, though, is what happens when they actually leave the hospital. True. They come to the hospital, they come to their doctor, they come to their physio, they go to their chiropractor, whatever it may be, their dentist, for example. But what happens when they actually leave those four walls? Yeah. How do we truly know that they are happily surviving in their communities and contributing in a way that is, bespoke to them? Yeah. We don't have that answer just yet. I think it's a real push and probably call to action for all of us to figure out ways to build trusting relationships with our community members for answering really difficult health-related questions.
That's great. And the next point in that conversation hopefully moves in the direction of all the devices that we have on ourselves today, specifically the fitness trackers, and everyone seems to be using one today. Is there anything that they produce that's of medical grade relevance? Did you look at that data? Because I know Apple is now working on data points related to mental health, for instance. So how close are they, and could they be considered medical grade data?
How exciting to hear you say that they're working on actually capturing data related to someone's mental fitness. It's the invisible sort of symptom, isn't it? Geez, you look great, Kariti, but I don't know what's going on inside. So to answer your question, I think I recall when I first started getting into actigraphy and tracking people's mobility issues. It's quite funny, actually. We had something that was about the size of a beeper. Now, you're probably too young to remember what a beeper is, but
more like the pager.
A pager, yeah. So they had a pager sort of device and a little strap around it, and we'd ask our patients or research participants to strap it onto their ankle and just wear it throughout the day. Well, you can imagine most people didn't really like wearing that because it was cumbersome. And I'll never forget one guy, we were tracking folks' data and their ambulatory steps during the day. And he came back, and I'll never forget downloading his data, and he had like 48,000 steps or something. And I said, oh, that's incredible. He says, I have to come clean. I actually put it on my dog's collar and I opened up the back door and let my dog just run around the garden for a while. Okay. So problems exist, but now, as you know, we've got it down my watch. You know, perhaps there's a chip that we can use in my phone. I'm constantly having that inter-competition with myself of, well, did I do better than yesterday? So do I feel like it's medical grade? Without a doubt. You know, we also work very closely with some other companies. Sangui Bio comes to mind, and Sangui Bio has sort of perfected this dried blood sampling. So if I wanted to take some bloods from you, I'd take some out of your vein, but we've got it down to dried blood sampling now, whereas if we educate the patient or the participant to give a little finger prick, they can actually put about 10 microliters of blood on a felt tip, pop it in the post, send it back to us, and we can get all the data we need in a very accurate, rapid fashion. So I think we're at that stage of just climbing this mountain at a rapid pace. So I think we'll see huge changes in not necessarily the way we intervene, but the way we assess before we intervene.
And on that process, would this be very similar to the consumer grade DNA test that people are engaging in today?
Yeah.
They have to send maybe a sample of their saliva, and then you get your test back on your ethnicity or where the mix could be and all of that. Would this be very similar to that in the future, where people could give a tiny drop of their blood, mail that in, and they get the results online? Or would that be a very similar process that you foresee? Or
I would think so. In fact, we've had this conversation quite a bit at the curriculum level design, say for physiotherapy, for nursing, for medicine. What happens when a patient spends $100 some odd to 23andMe and gives a little bit of blood or whatever, saliva, and back comes this lovely report? And then the patient, let's just say, hypothetically comes to the physiotherapist and says, hey, what do you make of this? It says I've got an ineffective catechol-methyltransferase gene.
Sometimes you wouldn't even pronounce them correctly.
Right. And so, does that influence the way that physio is going to assess that patient? Does the physio even know what that means? And I'm not knocking physio at all, because I was trained as a physio and the great clinicians, but that's an example where are we preparing our next generation clinicians to accept and deal with this information as it's coming in at rapid paces. I know friends of mine who they'll send their kids' blood samples into that to see, is our kid genetically sort of appropriate to be an ice skater or a hockey player or whatever it may be.